my talk, so I'm going to talk today about the teen with gender dysphoria and an eating disorder, and some of the medical considerations that come into play. I am currently at a private practice, but I still maintained my academic relationship with Montefiore and with Albert Einstein. So I sort of have these two roles, which is nice. So I have no financial disclosure, certainly. I do want to say none of the photos in this presentation are of actual patients. Okay. So just so that you know why you're giving 90 minutes of your life to listen to me, I wanted to tell you sort of how I came to this intersection of eating disorders and gender dysphoria. So I did adolescent medicine fellowship at Boston Children's. I think I went into adolescent medicine because I love talking to teenage girls about birth control and their sex lives and things like that. I really didn't have eating disorders at the forefront of my mind, but my fellowship was very heavily weighted towards that, and I actually really loved it. So when I left fellowship, I went to Montefiore and I became the medical director of the eating disorder program there. And that was sort of my main clinical duty. And then I was on the playground with my daughter and I was talking to another mom, and she was interested in adolescent medicine. She had never heard of that field. And she said, interesting, I'm a counselor for a support group for parents of transgender teens in Westchester County. And they're always saying that there's no doctor, you know, they have trouble finding medical care in the county. And I was like, well, I don't prescribe hormones or anything, but I can talk to them, and we teen doctors can talk about anything. And so somebody came to see me from her group, and then that person passed my name along. And before I knew it, I had a lot of gender dysphoric teens in my waiting room, and I realized I sort of needed to learn gender medicine because there was a need. And it grew wonderfully and almost magically in front of me. I developed a pretty big practice of children and teens with gender dysphoria. And so now I see basically the two. I think about half my practice is eating disorder management and half is gender dysphoria. And as you'll see today, oftentimes there's overlap. So, and as I said, I'm in a private practice at Pediatrics on Hudson. Shout out to people from my practice who might be watching me today. Thank you. So the objectives of today's talk are as follows. I'm going to talk about the basic principles of gender medicine. I have been told that the crowd today is from the world of eating disorders. And so I'm going to assume a certain degree of knowledge on that topic and do a little bit more 101 on gender medicine for you. And then we're going to talk about 4 cases that I pulled basically from my practice. All the details are details that are, you know, these are sort of representative archetypal patients that I've seen in my practice. We'll talk about a prodromal eating disorder in a gender dysphoric preteen, a transgender boy with anorexia, a non-binary adolescent with bulimia, and a transgender boy with anorexia purging subtype. And then I really hope to leave time for questions at the end or concerns or anything. So basic principles of gender medicine. This is the super bird's eye view, but I tried to encapsulate the important things. So let's go over just a lexicon a little bit to make sure everyone's using the right words. So the word sex is the designation assigned at birth based on genitalia or chromosomes. You're either male, female, or intersex at birth. This is a picture of a gender reveal party, which now we know is more like a chromosome or a genitalia reveal party, really. Gender is one's inner sense of being a boy, a girl, or somewhere on the spectrum between boy and girl. This develops earlier than we think in life, so it actually becomes pretty strong in a lot of children, even around age 2 to 3. If any of you have your own children, you might remember that around age 2 or 3, they started to really feel very fiercely what their gender was and talk about it a lot. And they probably started to divide the world into boys and girls. And that was like one of the most important things that they could note about somebody. I remember my 2-year-old son in the supermarket, and he was driving one of those little cars attached to the supermarket, the shopping cart, and he was honking, and then he stuck his head out and he shouted at this person passing by. He goes, "I'm a boy." And the person was like, "Yes, yes, I see you're a boy. There's no question." And it was an example of how fiercely he felt about that, even at age 2. So people often say, how can a child really know their gender? But the fact is that children really do. Gender nonconforming is a term that refers to dress, appearance, play that is out of the norm based on their birth sex, according to sort of like societal norms and expectations. So, you know, the boy that wants to wear a tutu, or the girl that shuns all kind of dress up and, you know, kind of the super tomboy. Gender dysphoria refers to distress. So gender dysphoria implies a negative feeling, and it's the distress experienced by the discordance between one's assigned sex at birth and the gender one feels inside. Transgender and cisgender. So transgender refers to someone who has an insistent, consistent, and persistent gender identity that is different from their sex at birth. And cisgender means the birth sex and the gender are aligned. So sometimes people stumble a little bit over this, so I hope I'm not sort of simplifying it too much, but a trans boy identifies as a boy. So a trans boy was assigned female at birth, but feels that he is a boy inside. A trans girl was assigned male at birth, but identifies as a girl. And actually, I really like this graphic because it's actually very helpful. Sometimes people like struggle to think of the right term in the moment, and it's just easy if you think of call the person what they think they are or what they feel they are. So a trans man is a man, a trans woman is a woman, a trans boy is a boy, and a trans girl is a girl. And you don't at all, you don't use the term of their, of their birth sex that they've sort of that they choose to, that they're rejecting, that doesn't identify them properly. Gender non-binary, gender queer, gender fluid, these are all words that really mean that gender identity is on a spectrum between boy and girl, and may even move along the spectrum over time. So sometimes people may say that they're trans-masculine or trans-feminine as a way of sort of describing what half of the spectrum they fall onto. So in terms of, how we actually manage this medically, so many children are gender nonconforming to various degrees in childhood. But not all gender nonconforming children are transgender. There are, boys who tend to be less masculine or who like to play more nurturing roles. There are girls who have always been described as tomboys. Like, we know these terms, and we sort of see this in children all the time. Not all gender nonconforming children are transgender. When it comes to the word transgender, what we're really talking about is how do people feel about their body at puberty? As far as we know, puberty is the litmus test for gender identity. So, if you have if you have a population of gender nonconforming children and you follow them out to puberty to see how they will feel about their bodies when they start to develop secondary sex characteristics, most will what we call desist, meaning they will identify with their birth sex and not go on to be transgender. About 4 out of 5 or 80% will desist at puberty. But about 1 in 5 or 20% will persist at puberty, meaning that they will go on to experience increasing gender dysphoria as their body starts to change. And that is a really strong indicator that that child is going to be transgender or is transgender, and that's manifesting. So when it comes to dysphoric children or gender nonconforming children, sometimes I do consultations with parents of 6-year-olds or 7-year-olds of gender nonconforming children, and the parents want to know, sort of what do I think of their child, and sort of what's my best guess, although I wouldn't use that language. And, there is some data and research to tell us which children will persist, and it's actually incredibly intuitive, and it's exactly who you think will persist. So the children who have greater dysphoria, meaning greater distress or negative feelings brought about by their birth sex, tend to persist at puberty and identify as transgender. Those who have a stronger desire to make radical changes to their appearance or to their name, so not just, a girl who really hates dresses and would rather wear, just athletic clothes, but a girl who also really wants her hair cut short and is trying to shorten her name to something more boyish and sort of actively rejects anything feminine. And those who say, I am a girl, not I wish I were a girl, or I want to be a girl, or sometimes I want to know what it feels like to be a girl. But when children definitively say, I am a girl, that's a really good sign that they probably are a girl inside. So what do prepubertal dysphoric children need? So, a lot of time I see more and more consultations for young gender dysphoric or gender nonconforming children. And the medical prescription there is very, very simple. When a child is prepubertal, what they need is unequivocal love and acceptance for who they are, the most important thing is within the four walls of their home. So the world is the way it is. Extended family can be, you know, sometimes not as understanding or not as informed. Kids at school may say something insensitive, but the most protective thing for a prepubertal gender dysphoric child is complete love and acceptance within their home. And that's been shown in the data, and I see it in my practice all the time, because parents can really buffer quite a great deal of stress or non-acceptance from the outside world. Parents are a great buffer, and we know that. Those of us who take care of children definitely know that. It's also helpful for young children to have a connection with a professional that will help parents navigate the next few years. So, you know, medically, it's nice to be connected to somebody such as myself. Endocrinology is another field that takes care of gender nonconforming children, adolescent medicine or endocrinology. And then to have a connection with a mental health professional is also really helpful for parents. Parents need lots of support during this time. Oftentimes, if they've allowed their child to be gender nonconforming and to express themselves the way they want, and they've given their child the haircut and the name and the clothes that they want, a lot of young children actually do really well and are pretty content and end up not thinking about their gender very much. They're sort of busy being kids. But what you're left with are parents that are sometimes really hurting and really kind of grieving the child they thought they had, and just they can sometimes feel adrift or resentful or all kinds of negative emotions that oftentimes they hide from their child, and you can be kind of a sounding board for them to listen and to connect them to supports for themselves. So puberty is the litmus test for gender identity. Puberty needs to be allowed to start, but I do tell patients and parents, we don't let it get very far. Breast budding is the first sign of puberty for people who are assigned female at birth, and it is very subtle at first. And testicular enlargement is the first sign of puberty for people who are assigned male at birth.
Dr. Dodson, sorry, quick question. Regarding your previous slide where you had the 80% and the 20%, a question just came in, which was, is it 80% of gender non-conforming children or all children who desist?
Oh, so it's 80% of gender nonconforming children. So these are sort of, you know, this is data from sort of back when gender care was centralized at like a few gender programs in the country. There were, you know, there was research done on populations of gender nonconforming children. And it was found that if, you know, out of 5 gender nonconforming children, 4 of them will desist at puberty and identify with their birth sex, and 1 will go on to persist at puberty.
Great, thank you.
No problem. Good question. So yeah, so these are the pictures. If you're in medicine, you've seen these pictures a million times of the 5 Tanner stages of puberty. So at stage 1, you look like a little kid, and at stage 5, you look like a grown-up, and then 2, 3, and 4 are in between. So puberty blockers it's just an important, it's like the first medical intervention that we discuss with persistently gender dysphoric children. So I wanted to tell you about them. So pubertal children with gender dysphoria can receive a medication called GnRH analog or a puberty blocker. And these medications are given as an injection in the arm, either every 1, 3, or 4, or 6 months, depending on the formulation, or it can be a subdermal implant that actually can stay in place for a year or even longer. They temporarily pause puberty, so they are not a permanent intervention. And as far as we can tell, they don't have any permanent effects on pubertal development if they were to be stopped for any reason. It's really good to have a connection with a mental health specialist as this process happens, not because there's something wrong with the child, but, you know, or that there's something pathological about gender dysphoria, but just because it's kind of good to it's good to take this time to find a connection with somebody that you connect to, that the child actually likes and has a connection with, because as the child gets older and we start to consider more irreversible interventions, we are going to need the involvement of a mental health professional. So it's good to start searching now for the right person. Puberty blockers are a reversible intervention, as I said. I think that's the important thing to know about them. So the benefits of puberty blockers are manifold. This is a wonderful, wonderful medication. First of all, there's just relief from psychological distress. I mean, I have taken care of kids who really cannot get out of bed until that puberty blocker is given. They are so distressed, and in their mind, every day their breasts are getting bigger and bigger, and they just can't face school, and they can't face the mirror, and they don't want to take a shower. And puberty blockers just give them a wonderful sense of relief. It gives the parents and the child time to just take a deep breath and let gender identity unfold so that more informed decisions can be made later on for the child. Importantly, someone who chooses to go on to transition later on, they're going to sort of, quote, look better, like the transitional hormones are going to be more effective in those who have blocked their own puberty. This is a picture of the very famous Jazz Jennings, one of the first transgender children to kind of live publicly, assigned male at birth. By age 2 was saying, actually, I'm a girl. And the parents kind of went public with her journey. She had her puberty blocked at age 11 and has since transitioned all the way, including surgically. And as you can see, like just looking at her bone structure, she clearly has never gone through a masculine puberty. She doesn't have a square jaw. She doesn't have a strong brow. She doesn't, if you hear her talk, she doesn't have a deep voice. So she was sort of spared all of these physical effects that would have made it harder for her to appear female later on in life. And so someone's quality of life is just so much better the more you can get them to be, quote, passable in their identified gender. As I said, and especially I think for trans girls, it's just really good for their well-being to be able to truly appear feminine, even as a protection against like discrimination and violence, which a lot of trans girls and trans women are vulnerable to. So not all children express gender dysphoria in early childhood. Some express it once they become teenagers. So adolescent onset gender dysphoria is a very well described phenomenon, and they may first state that they're having gender dysphoria after they've had a period or after they've gone, most of the way through a male puberty. So this is definitely something that I see probably more often than early childhood dysphoria. There's no role for puberty blockers beyond about 10 or stage 4. Once somebody is, 4/5 of the way through puberty, the benefits of blockers really don't outweigh, the risks and the headache to parents and the process of taking the medication. So when I do have an adolescent with new onset gender dysphoria, first of all, I always encourage expression and gender exploration. So just because we're not prescribing a medicine that minute, it doesn't mean we don't affirm them and say, I believe you. I believe that you're a boy, and I think that you should actually use your physical appearance to look as male as you can, because it'll make you feel better. Trans boys can receive menstrual suppression. So that's a fairly easy medical intervention, and that's something that can be provided. It's basically the birth control. It's basically various forms of birth control can be given to achieve menstrual suppression for trans boys. So that's not a terribly big medical decision to make. People often want to know, well, what about hormones? The actual hormones that change somebody's body. So teens with a persistent, insistent, and consistent gender identity are candidates for gender-affirming hormones. These hormones have permanent and irreversible effects on the body, including on fertility. And so this is a serious sort of medical decision, and it's only done after a thorough evaluation and a strong recommendation by a mental health professional that knows the patient well. It does require parental consent. And I want to go beyond consent. I really like it when the parents are fairly excited, and that can take a little while, but families do get there, even though it's quite a journey for them to go on. The guidelines really state that a child should be 15 or 16, but they do give wiggle room. They say, consider younger ages depending on patient circumstance. And so I do consider younger ages for children who have really had early onset gender dysphoria and have, since toddlerhood or kindergarten, identified as transgender. Uh-oh, my dog is barking. I kind of predicted that. So in terms of hormones, I'm going to shut the door. Sorry. I have a dog and a cat and 3 kids, and I was taking every last precaution to make sure that nothing would interrupt this talk. So in terms of gender affirming hormones, so trans boys receive testosterone. It's very straightforward medical regimen. Actually, it's really a 1 medication regimen. Trans girls receive estrogen, and increasingly I'm giving progesterone as well, the 2 predominantly female hormones, and a testosterone blocker, because they really do need to turn off their own source of testosterone to have a good effect. The regimen starts low and goes slow to mimic puberty. I'm really just trying to mimic nature, and I'm a pediatrician first and foremost, so I tend to be on the conservative side in terms of, giving medications to young growing bodies. So we give it low and we go slow. And the eventual goal is to reach physiologic hormone levels of cisgender people, no more or no less, but that process can take 2 years, okay? So let's get into the case vignettes. So now that I've educated you all on gender medicine, let's introduce eating disorders and how they appear among transgender teens. Okay, so these are what I think of as 4 kind of archetypal situations. So first, let's talk about a prodromal eating disorder in a gender dysphoric preteen. So Maddie is a 9-year-old child assigned male at birth. He's always been a picky eater who is small for his age, but grew normally along the 10th percentile for BMI. Now he's getting more picky, rejecting the few foods he used to like, and causing fights at the dinner table. Mom thinks he's melancholy and withdrawn. For several years, Mom has wondered about Maddie's gender identity. When he was in preschool, he would always put on princess dresses at playtime. He often comes home from school, takes off his clothes, and puts on something from his sister's closet to wear for the afternoon. When he was younger, he asked his mother if a fairy would come and take away his penis. Remember, all of these details are from my patient, so my patient did ask their mom that. And as he got older, he stopped asking about that. Probably because he realized it wasn't received very well, or that it wasn't really acceptable to ask about such things. So on exam, Maddie is 10 or 2 in early puberty and thin, small for his age, but not particularly cachectic or sickly. And the BMI curve shows that he's been on the 10th percentile, but is starting to drift closer to the 5th percentile. Vital signs are normal. And so your sense is that this is a medically stable child who's just sort of slipping off his already small growth chart. So I'm not going to spend time talking about the eating disorder evaluation, because you guys know how to ask questions about eating and how to get a diet recall. I wanted to just give a little pearl about how to get young kids to talk about their gender identity. So Maddie was very quiet and shy, and really couldn't even make eye contact when talking with me about gender. Really almost wanted to be in Mom's lap, and was very scared to say anything out loud. Mom was very supportive and was there to listen, but you could tell that this was something very deep inside Maddie. So what I did was I actually had him, I said, can you just draw emojis for me? And I gave him paper. He's not he anymore, Maddie is she now, but I gave Maddie paper, and I said, how would you feel if your body went through puberty and you developed male features like a teenage boy, like the teenage boys that you see in middle school? And we described those features. And I said, you don't need to tell me, just draw an emoji on the paper. And he drew he drew a very sad face and slipped it back to me. And then I said, if I were to ask you if you feel like a girl, a boy, or something in between, how would you answer that? And he wrote, a girl, but my sister won't like it. And then I said, how would you feel if you grew up and looked like a girl instead of a boy? Can you draw an emoji? And he drew a happy face. And this Mom had sort of started to suspect that, as I said, Mom had started to suspect gender dysphoria, and this sort of allowed it to be fleshed out. Maddie already was in the care of a therapist, and so this kind of was more concrete evidence that Maddie was experiencing gender dysphoria. So Maddie was, I'll call Maddie she from now on, because eventually Maddie did become she. Maddie is a peripubertal child with gender dysphoria and an early prodromal restrictive eating disorder. In my mind, this is Peter Pan syndrome. This is a phrase that I used in fellowship, and I sort of did a little Googling, and I don't know if people actually use it to describe what I'm describing, but it's a perfect description. It's that Maddie really didn't want to grow up because growing up meant going through a male puberty. And so Maddie was sort of using starvation as a natural puberty blocker. Probably kids do hear all the things that we say to them, like, oh, you're eating, you must be growing, you're having a growth spurt. And so kids know that, eating well leads to growth spurts and puberty. So gender dysphoria was really driving this, this prodromal eating disorder. So really my medical goal was just to return to normal eating so that Maddie could return to his growth curve, now her growth curve. So I made the marching orders very clear. I said, Maddie, your job is to eat what a 9-year-old should eat, which means anytime you're hungry, you eat. If dinner's really delicious and you want second helpings, you have second helpings. If it's 3 o'clock in the afternoon and there's ice cream and you want to eat it, you eat it. And so I really tried to reinforce, you've got to be eating freely and with abandon because you're a growing kid, and there can be no restriction in the face of hunger. And then I said, my job and your mom's job is to make sure that you don't suffer through a puberty that's wrong for you. So I sort of said, don't worry about that at all. We're going to take that off of your worry list. And your only job is to eat and grow. And even though you might keep growing taller, if you're not meant to go through a male puberty, you're not going to go through a male puberty. And that was sort of all that Maddie really needed to just have that worry kind of taken away. My first approach is the family-based treatment model with someone like Maddie. Even if we don't do formal FBT for a child like this, so certainly the idea is like, Mom, you know what Maddie's favorite foods are, and tonight for dinner, why don't you plate Maddie's food in a portion that you think is robust enough? And it worked really well. I also helped to connect the family with a mental health professional with dual experience in gender dysphoria and eating disorders, and to sort of help guide them through that. Maddie had frequent medical follow-ups to track height, weight, and BMI, and eventually used a puberty blocker with a GnRH analog. Okay, the next case, and Melainie, stop me if there's questions. I'm just gonna keep going through, but anytime.
No, that was great, really great. Thanks, Dr. Dodson.
Awesome. Okay, my next case is a transgender boy with anorexia nervosa. We're turning up the heat a little bit on medical instability or medical worries. Okay, so this is Kai, birth name Carolina, a transgender boy, 14 years of age, coming to see you with a diagnosis of anorexia nervosa given by his pediatrician. He has lost 37 pounds and dropped from the 55th to the 7th percentile for BMI in 18 months. His eating changed in April 2020 after seeing memes about pandemic weight gain and learning that COVID was more dangerous for overweight people. I'm sure all of your appointment books are booked to the brim because of COVID-related anorexia. Something about being home with all of that internet access has just caused skyrocketing eating disorders among all teenagers. Certainly not just gender dysphoric ones. So I chose this picture for a reason, because this is a picture of a boy who looks kind of sad and isn't really there. And as you know, teens with anorexia, they're not really themselves. They sort of start to have that kind of flat anorexic faces a little bit. And one mom said, my child has lost their sparkle, which is a really great way of describing what anorexia does. So Kai has identified as a transgender boy since age 11. Breast development at 9 caused dysphoria. The dysphoria worsened over time and worsened by the onset of menarche or first period at age 11. That's when, Kai, the dysphoria became so overwhelming that Kai was able to say, I don't think this is right. I don't think I'm a girl. In therapy, Kai came to express his transgender identity. And he's been out as Kai, he, him, or his pronouns, but has not received any medical interventions, because by the time he spoke the words, as many children do, he was already, pretty far into puberty. Once somebody gets their period, they're at stage 4, basically, of pubertal development, and that's pretty far along. So Kai menstruated monthly from age 11 to 13, but his last period was 5 months ago. On exam, he has a heart rate of 50. He has a low normal blood pressure for age, a sallow expression, and cool extremities. Kai's lab work shows leukopenia, which means low white blood cells, normal electrolytes, something called sick thyroid syndrome, which is where you have a low T3 because it takes a lot of energy for your body to make T3. So when your body is starving, it stops making as much T3 and it makes T4 instead. So you see a low T3. No anemia. People often expect to see anemia, but you actually don't see anemia because Kai hasn't menstruated in 5 months and so has held on to every last red blood cell and usually has a better hemoglobin than most people in the room. So this is really classic lab work for anorexia. All I often see is a low white blood cell count and a low T3, and everything else looks normal. So it can be falsely reassuring to parents when they see normal blood work. So the diagnosis for Kai, he walked in with it, it's accurate, anorexia nervosa. In my mind, anorexia nervosa is a medical emergency, and it sort of takes precedence over everything else, over gender-affirming care for the time being. So while we're talking about anorexia, I'm always affirming and supporting Kai's gender identity, but we're focusing on weight restoration because that is the medical emergency. So really, what are the goals of medical management? So in my mind, what's my job when I see a patient? Because a lot of times I'm one member of a very robust treatment team. So my job is to make sure parents know the medical risks of anorexia nervosa, to discuss the prognosis, and to set parents on a treatment path. So in terms of the risks of anorexia nervosa, osteoporotic fractures are one of the ones that we think of most often and that doctors talk about because it's very kind of concrete medical thing to talk about is bone health. People often think that it's just because you lose your period that like, oh, you lost your period and so you're not making estrogen and so your bones are getting weak over time. But it's way beyond that. There's about 10 hormonal irregularities in the body of somebody with anorexia that are bad for your bone density. So it's beyond just periods, and it probably affects people who are male as well. The way I describe it to parents is I say anorexia is toxic to bones. And when I'm talking to a teenager and their eyes are kind of like glazed over while I talk about the risk of fractures, I try to remind them and mom that we're not talking about the type of fractures as when you fall off the jungle gym and you break your arm as a little kid and you're fine 6 weeks later. These are fractures from low bone density that can debilitate you for the rest of your life. And that when, people get osteoporosis, they actually have a shorter life and a worse life because these are the type of fractures that really debilitate people. Cardiac arrest. This is definitely a wake-up call for parents to hear about, but I do mention the risk of cardiac arrest and early death from anorexia, mortality. But the things that probably doctors don't talk about enough that we should really talk about more is, first of all, anorexia causes a loss of normal adolescent development. So teens stop being teens when they have anorexia. They lose all interest in the world. They stop exploring different identities and interests and all the things you're supposed to. You have a really important job to do as a teenager. You're supposed to be learning about relationships, having crushes, having friendships, developing a political identity or a social identity that's different from your parents. None of that can happen when you're sort of being held hostage by anorexia. So I think it's really important for doctors to speak to that. Anorexia steals the best, which not the best years, but what should be really important, good years of your life. Hopefully the teen years are not your best years. And lastly, the real risk of anorexia is more anorexia. So when people have anorexia nervosa and it goes untreated, the risk with every passing month increases that they will develop chronic anorexia, which is a chronic medical illness that just is a terrible, terrible it's a terrible condition to carry into your young adulthood. I take care of some young adults with chronic anorexia, and they really don't have a full life. They're really either chronic patients or their life is very stunted by their illness. And again, they're not in relationships, they're not living independently. So I really try to raise parents' anxiety level to a functionally, but I want them to really see, let's get rid of this disease now so that it doesn't become a chronic problem for your child. This is my super scientific graph of prognosis. So over time, I've sort of simplified it because this is close enough to the truth that when you look at all adolescents with anorexia, about half have an excellent prognosis and half struggle more, meaning that they, suffer with chronic anorexia or even, this includes the group that can even have early mortality. And what determines the positive, or I should take out bad and good, but what determines the more favorable and unfavorable prognosis? It's really time to recovery. It's how quickly can we get somebody's weight restored. So every month counts. When it comes to the treatment of anorexia, this is another thing where I think medical professionals should be very descriptive and talk very sort of descriptively about what it takes to recover from anorexia. First of all, I am a big champion and believer in family-based treatment. I've seen it work wonders in my patients. So one of my first jobs is to connect families to really good FBT trained therapy, especially for younger teens, and possibly also a dietitian. And that's an individual decision that, as you guys know, based on sort of the family's comfort level and what they think they need. Then I prescribe the medicine, which is food. And I let parents generate examples because I really want parents to remember that they did a great job feeding their child before anorexia came along, and that they can probably name 10 meals right now that would put weight on their child. One of the most kind of emotionally satisfying experience as a parent is watching your child just fill up on really great food. And so this is something that it kind of gets at parental instincts. And, we all know that feeling of watching your child face plant into an ice cream cone. So I try to generate that feeling in them again and say, what foods, did Kai used to love? Oh, he loved spaghetti and meatballs. That's a great meal. What could you do to make that meal a little bit more robust? Awesome. Garlic bread. I love it. You have tonight's dinner, and just get them to feel empowered again, because eating disorders make parents feel out of control. And then I educate parents on why their child needs to eat so much food to gain weight. And for that, I really turn to some evidence from that we have. This is the study from the 1940s. You guys probably know about the Minnesota starvation study, where conscientious objectors were agreed to be starved, basically, to help the US Army figure out how to refeed starving populations. And what they found was that these men sometimes needed upwards of 3,000 calories or close to 4,000 calories to actually start gaining weight. So I do actually describe this study to parents so that they get why their child needs to eat so much food to gain weight. We now have genetic evidence too, that there's a paper in a very kind of high-ranking journal, Nature Genetics, that studied the genomes of people actively sick with anorexia. And what the paper found was that people with anorexia actually their DNA turns on genes that make it harder to gain weight and that cause them to increase physical activity and feelings of restlessness. So what this really means is that when you have anorexia, nature is working against you, and you need to fight against that with every single meal. So focus parents on nutrient-dense, fattening, high-calorie foods. This is a picture of mac and cheese with bacon, and this is just perfect. My trigger word is avocados, because those who worked with me at Montefiore knew that I needed a bell to ring whenever people said avocados, because it's something that your patients, I'm sure you've heard this, will sort of use it as an example of the fat they ate that day. Well, I ate avocados, and I love avocados personally, but they don't cause anybody to gain weight. So we have to actually describe foods that do, like macaroni and cheese. So this is the smartest wisdom ever stated on eating disorders from Hippocrates: let thy food be thy medicine. Because when it comes to anorexia, food really is your medicine. So for vital sign abnormalities, when you have bradycardia or hypotension or hypothermia, food is what brings those numbers back to normal. Depression, anxiety, OCD symptoms, oftentimes they only appear when somebody's malnourished, and feeding them properly and getting their weight up is what will restore their mood, much more so than any medication. Bone health. Similarly, there's some evidence that after 6 or 12 months, transdermal estrogen can help the bone density of somebody who has lost their period, but I found it's no replacement for food. And so we really need to focus patients almost singularly on weight restoration. Okay, take off your caps of that patient. Let's put on another thinking cap. We're going to talk about a non-binary adolescent with bulimia nervosa. So the point of the prior case was just that anorexia is an emergency, and it's sort of in it, and it has to take precedence over treating gender dysphoria. Now let's talk about a non-binary adolescent with bulimia. Lex, birth name Alexis, is a 16-year-old adolescent, assigned female sex at birth, but identifies as non-binary and uses they, them. Lex sees you for gender-affirming care and for their eating disorder. They have a diagnosis of bulimia nervosa, binging and purging approximately 1 to 2 times a day for the past 4 months. They are in therapy with an eating disorder therapist. I intentionally put a picture of Lex in which they're smiling and they appear, you know, easy to talk to, because as you know, patients with bulimia tend to still kind of maintain their own personality, like they're still them a little bit, and they tend to sort of maintain their warmth and communication and things like that, as opposed to the more kind of sallow picture of Kai before. So they have identified as non-binary for 2 years, and they describe dysphoria around their chest and their periods, which come monthly. They really want menstrual suppression. That is what they're there for. They're like, make these periods stop. Lex is a well-appearing adolescent in gender-neutral clothing, short hair. They're communicative. They're warm. They're rational. The BMI is 65th percentile, consistent with the childhood growth curve. So this child's weight hasn't really changed that much with the onset of this eating disorder, or BMI hasn't changed that much. Vital signs are normal, and the physical exam shows Russell sign, which are the calluses on the MCP joints of the hand from purging. Lex's lab work shows no anemia, normal thyroid tests, no leukopenia, and normal electrolytes in italics, because that's the most important thing when you're evaluating Lex, is Lex throwing up enough to make their electrolytes abnormal. So Lex's diagnosis is bulimia nervosa, and they're medically stable. So how can we balance eating disorder treatment and gender affirming care? I would say Lex is in a place where actually we can do both, and we don't need to push either one off the table. They can both stay there. So in terms of the principles of medical management for bulimia, my job is way smaller when it comes to bulimia than in anorexia. I feel like with anorexia, I have all this counseling, you know, I just spend tons of time counseling and describing and managing a lot of the medical comorbidities. I sort of stand back a little bit with bulimia. My job is to ensure medical stability, and my job is really to say, this person can keep being treated as an outpatient. They do not need inpatient treatment for an electrolyte abnormality. Basically, is the potassium normal, and is the weight maintained? Because if somebody with bulimia nervosa starts to lose weight and restrict in addition to it, and they start to look more like anorexia purging subtype, well, then my role grows a lot bigger, because that's much more of a medical emergency, and they may need, you know, a higher level of care. So those are really my 2 questions when I'm taking care of somebody with bulimia. The most important thing is that they're connected with mental health care, with somebody who is, you know, comfortable treating purging eating disorders. And that's where the hard work really happens. This person, you know, Lex is going to continue to work in therapy on decreasing the frequency of purging. I can come back into the picture, or a psychiatrist can come back into the picture, if the team feels that this is a patient who would benefit from fluoxetine, because there's evidence to show that fluoxetine decreases binging and purging in adolescents and young adults with bulimia. So for medically stable patients, my goal is not to have them stop throwing up and make sure they never throw up again. It's more to decrease binging and purging over time. It's like it's almost like any harmful habit that somebody works on in therapy, and the hard work is done in therapy. The patients stay rational. And that's really important. So they're rational about their health. They're able to communicate very kind of lucidly about things. And so they're able to engage about other issues while working on binging, purging, and therapy. So Lex comes in for regular lab work, weights, and vital signs. I do evaluate for other forms of self-harm because purging often comes with other forms of self-harm like cutting, high-risk sexual behavior, drug use. And then I can proceed with menstrual suppression with a progesterone agent, such as progesterone-only pills, an IUD, or medroxyprogesterone injections, which is known as Depo-Provera. And I use progesterone agents for non-binary adolescents or trans-masculine adolescents or non-binary because they tend not to want any estrogen effect. So the traditional birth control pill is not going to make them very happy because it can cause breast enlargement and things like that. The last case I'm going to go over, and I think we are going to just about make it, is very much based on a real patient that I had and that I still have, was one of the first patients that came to see me in my new practice, actually. A transgender boy with anorexia purging subtype. So this is like red flags should be going off, hopefully, when you hear about this patient. So Milo is a 15-year-old adolescent identifying as a transgender boy, he, him, referred to you for eating disorder management. That's the reason that he walks through the door, the reason for the consultation. In the past year, he's lost 15 pounds, dropping from the 25th percentile to the 3rd. He did this by restricting, using laxatives, and purging 1 to 2 times daily after normal or small meals. He has a history of non-suicidal self-injury. He has identified as male for the past 1 year. He's gone through several name changes, and he says he is desperate for testosterone. So his mom is there to talk about the eating disorder, but he is there to ask you when he's going to start testosterone. He was sexually abused by an extended family member when he was 10. He has been through 2 residential psychiatric admissions, and he is without stable mental health care right now. On exam, so this is like one of these, you come out of the visit and you're like, how am I going to triage all of these issues? And just at first blush, when I met Milo, none of these are the real names, and I should have said that from the beginning. When I met Milo, I knew that we were going to have to really do some prioritizing, and that gender dysphoria was probably not going to be my first medical concern for Milo. On exam, Milo is cachectic at about 80% of ideal body weight, but with normal vital signs, dressed with feminine and masculine elements to clothing with close cropped hair, deep cuts in various stages of healing on wrists, thighs, and hip bones, the type of cuts that could conceivably either, first of all, cause scarring or become infected. The communication style of Milo was very provocative and inappropriate, but Milo denied suicidal ideation. Milo's lab work again showed leukopenia, which we saw with our first patient with anorexia, and a low T3. So that means Milo's malnourished for sure, no anemia, and hypokalemia, so a low potassium of 2.8. So again, it's like all the lights are going off, right? So Milo has quite a list of adolescent issues going on: anorexia purging subtype, non-suicidal self-injury, history of sexual abuse, and then gender dysphoria, which again, I didn't bold and I didn't italicize because in terms of the mental space to take care of Milo right now, we have to sort of put that a little bit on the back burner. So anorexia purging subtype is a true emergency. There's a high risk of mortality from cardiac arrest. I think, these are the patients that are found, dead, that have died in their bed from a cardiac arrest. So hypokalemia has to be treated on an inpatient medical unit for sure. Patients tend to be kind of total body depleted of potassium. So it has to be administered either orally with tablets or in their IV fluids, and then checked and rechecked because it can sort of continue dropping because their body is just very depleted of potassium. So Milo has elements of borderline personality, and I think hopefully that comes through even in the few slides. And I know that there's a back and forth about whether we make that diagnosis in the adolescent age group, but I would certainly say Milo has risk factors for borderline personality disorder and elements of his behavior that are consistent with borderline personality for sure. He's been undertreated for severe childhood trauma. And regarding the sexual abuse at age 10 and the fact that he really hasn't had consistent mental health care since that time. And he has a life-threatening eating disorder. So gender dysphoria really cannot be treated with a medical intervention at this time. But gender exploration and expression should be encouraged. So, you know, this has been, I've had so many conversations with Milo about this, where I say, I completely believe you that you're Milo and that you're a boy and that you want to transition. And, you know, right now we have to prioritize the things that are threatening your life, but I completely believe you and nobody's doubting that about you. So I do affirm his gender. So what I really do with a patient like Milo is I just really try to build a rapport with him and with his parents. And I say, listen, we are in this for the long haul together. I'm not going anywhere. I'm your doctor. You know, you have a lot going on, but I think we can address everything over time. The best wisdom on gender medicine is that if you listen to a child long enough, they'll tell you their gender. And so what I say to Milo and to his mom is, I'm here, I'm going to listen to you, and over time, we're going to figure out the right thing for you. You know, when you talk to therapists about children who are gender nonconforming or who are identifying as transgender, and you ask, like, well, you know, do you ever evaluate somebody where you are not sure that they have a true transgender identity? What is that like? What are the situations that lead to that? And one of the situations that can give people pause when they think about transitioning a teenager is a history of sexual abuse, particularly if the trauma hasn't been properly treated, because that can certainly influence that teen's gender identity in the moment. And, you know, they're identifying with their aggressor or, you know, rejecting their female body. And so for someone like Milo, I'm going to take it very slowly and really try to stabilize all of his other life-threatening mental health conditions before we begin to medically intervene on the gender dysphoria. So if you listen to a child long enough, they'll tell you their gender. So I guess my takeaway messages, because I'd love to leave time for questions, is transgender are the following. So transgender children deserve care that is affirming, but also thoughtful and cautious and judicious. Active anorexia, restricting or purging type, must be treated before any interventions for gender dysphoria. But bulimia nervosa can be co-managed while gender dysphoria is addressed. So the patient that I talked about, the non-binary adolescent with bulimia who wanted menstrual suppression, such a patient could also, if that patient was an appropriate candidate for gender affirming hormones, I would have also proceeded as long as, you know, as they were in therapy and medically stable and being supported in that decision by their therapist. So I hope that's helpful, but I think maybe the most helpful thing I can do is wait for your question so I can see what I missed. All right, so thank you so much.
Dr. Dodson, that was so informative, and actually I realized that I myself, and I wonder if our participants have gone to a number of presentations on non-binary, etc., but more from a psych or psychological perspective. So this was my first presentation on the medical, and I have to say it was just incredibly informative. So thank you for that. We've got a couple of questions here. One of them first from Sarah Palotto says, what is the prevalence of binge eating disorder and gender dysmorphia? Dysphoria, excuse me.
Yeah. You know, the numbers I would be making up if I said them, but it's there if I made up a number, but I have definitely seen it, and it almost, you know, when you see binge eating disorder, one of the ways it manifests is almost as the flip side of the Peter Pan syndrome. So people use starvation to prevent, you know, feminine curves from forming, or whatever the puberty is. You know, people use starvation as a way of stopping puberty from happening. And people also use binging probably as a way of sort of like padding or hiding their body and making their body look agender. So I definitely see it, and I wish I had the prevalence. I'm going to try to get that number and get it to Melainie, but I see it. And then it also is a disorder that, as you know, kind of can morph back and forth with bulimia. So patients will binge and do something to compensate, and that's bulimia. But then if they stop doing compensatory measures, then it becomes binge eating disorder. And you see it, people do kind of use it as a way of creating, a gender-free body, or making, their feminine curves disappear, sort of.
Absolutely. And actually the next question is quite similar, but specific to transgender. So this is from Susan Gilbert. She asked, would you please speak about transgender patients struggling with binge eating disorder?
Yeah, so I have seen it. In my mind, it tends to, the patients that I've seen with binge eating disorder have a presentation a bit similar to the patients with bulimia, in that it's one of many harmful things that they're doing to themselves. And so, I've had patients with binge eating disorder who are also cutting, or who are also engaging in high risk sexual behavior. The reason that medically it becomes important for such patients is because first of all, if it leads to a lot of weight gain, it can. I had one patient in particular where it was really getting in the way of that patient being able to have the gender affirming surgeries that they really needed to be happy. It was a transmasculine patient, and he really needed top surgery to be happy. We can talk, if people are interested, about the importance of top surgery, or chest masculinization surgery. But there was the roadblock up because of his BMI, because binge eating disorder had led to a BMI that was quite unhealthy. And so the plastic surgeon was not willing to do what they consider a cosmetic surgery on somebody with an obese BMI. And that was really devastating. So for that patient, controlling their binge eating disorder was going to be sort of had to take precedence in order for them to move forward with the gender confirming surgeries that he really needed.
Wow. Thanks so much. And, Dr. Dodson, that brings up a lot in our field that we've been talking about, with health at every size and BMIs, and even the term obesity, that medical term, and we understand that in the medical field it's used. But there's a lot of questioning right now around the significance of using those BMI ranges with respect to refusing certain surgeries, and whether they're quite arbitrary, actually. Yeah. So I'm wondering if you've been hearing a bit about that.
Yeah, it's really interesting. It's the more I do this work, the more I want us, almost as an entire planet, to stop thinking about the number on the scale. It's just so, I just the mental space that it takes up for the whole world, worrying about what their weight is and what their BMI category is. When you talk to transgender people, one of the things that I say complain, and I don't mean to diminish it. One of the things that they say that's really hard for them is the feeling that the medical world puts up all these roadblocks for them, that accessing gender affirming care is just one roadblock after another. And I see it. It's, you have to get letters from everybody to, every intervention that you need a letter from a psychiatrist and a therapist, and all these. Every roadblock makes them feel more and more diminished. And the fact that they are sometimes prevented from having the surgeries that they need, I think it is quite harmful to them, and probably quite arbitrary. When I first started this work, I didn't fully understand the importance of top surgery to transmasculine adolescents, So I would start a teenager on testosterone, and I would sort of in my mind be like, okay, this is going to really make them feel better, and it'll probably be a while before they start asking for any more medical interventions. And what I found is that almost immediately, they started asking for, they started asking for top surgery, which is more technically called chest masculinization surgery, or a mastectomy. And what I came to realize is that if we withhold the surgery from people, we're really asking them to masculinize and have breasts and have basically a female form. And that's devastating for people. And it's the absolute opposite of what they need in life to be happy. They need to look like a male, they need to be male. And actually the data show that, that chest masculinization is one of the ways that you can really help people's mental health. So I do think that it's it's a situation that we have to deal with as a medical field, that we're withholding this surgery that is so profoundly good
Right.
for people's mental health because of an arbitrary BMI cutoff.
Yeah, absolutely. Absolutely. So, and I'm glad that to hear how you're thinking about that as well. And I'm sure our participants are as well, because certainly from our transgender and clients, you know, we're hearing similar things about, my goodness, why is the medical field putting all of these barriers to gender affirming care? And it's, yeah, absolutely. Let's have a look. We've got lots of questions pouring in.
Sure.
This is fantastic. Okay, so the next question then is, this is just about your availability. Does Dr. Dodson, this is from, excuse me if I'm pronouncing it incorrectly, Ealing. Does Dr. Dodson do virtual intakes or visits for patients who live in Manhattan?
Yeah, I do. Thank you. Yeah, I absolutely do. Yeah, the pandemic taught me, man, you can do a lot virtually. So, you know, more than you think you can. I've walked people through their first testosterone injection virtually. And yeah, so I absolutely do. And what I have found is that even with home scales and things, you know, you can do a lot of care virtually. So
absolutely. Yeah. Fantastic to hear. The next one from Sari. Can you speak to which growth charts you use for transgender patients? When do you switch growth charts, or do you ever switch? Great question.
This is, if I were more tech savvy, there would probably be a way to switch it in the EMR. What I end up, you know, we do need growth. We need a better system. What I end up doing is just using my own kind of gestalt when I look at their growth chart, and sort of correcting in my mind, you know. Those growth charts don't exist for, you know, people who've transitioned genders. They don't exist. And one thing that's a bit hard is that there's very, very little data on height and transgender adolescents. So, you know, with a cisgender adolescent, you can make a pretty good height prediction based on parental height, and their growth chart as to how tall they're going to be. And you can't make any such predictions really with transgender adolescents. So that's a good idea.
And do you mean that you can't make any such predictions because of, if they do participate in some of these hormonal treatments, that therefore you're not able to predict what will?
Well, it's more like, so you know, like, I feel like no one on earth likes their height. Everyone wants to be taller or shorter. And the same is true for adolescents, and the same is true for trans adolescents. So, you know, my one issue is, you know, my trans boy patients want to be taller. They all want to be taller. And the problem is that oftentimes by the time they've come into care, a lot of times they've had their period already, and the estrogen has closed off their growth plates. And so they want to know, if I take testosterone, will I grow taller? And I get a bone age x-ray on them to see if there's any opening of the growth plate. And if the growth plate is open, the only thing I can say is there's a chance. And so let's all knock on wood and hope. But it's not like with a cisgender teen where I can actually use charts and say, oh, based on how closed your growth plates are, you can expect another 2 inches. You know, it's there's no certainty. And the same with trans women. So trans girls really bemoan, they don't like to be too tall because they feel it's something that can out them. And so they really want that estrogen to close off the growth plates. And it will, but we can't predict how long it will take to do that, how many extra inches are going to eke out, that kind of thing.
Sure. And I'm a registered dietitian by training. And so we use growth charts a lot for our eating disorder clients, right? To understand it, you know, if they've fallen off their growth chart, their growth curve, then what's the biological kind of best weight or optimal weight or goal weight, shall I say, for them. So if we have a transgender boy who hasn't yet gone through any kind of hormonal treatment and such, and they're struggling with anorexia and weight loss, would we be best to use the growth charts which are showing their sex as female? So it's a female growth chart and just following that curve through. Is that the best way to proceed?
That's what I would do, because I would think, I would say physiologically they're still they're female. And
Right.
yeah, I would absolutely use their childhood growth chart. And that's what I use to try to find what I think someone's target weight is. I try to say, well, where were you when you were healthy?
Right.
And yeah, absolutely. And even when they transition, to be honest, the weight changes aren't so dramatic.
Mm-hmm.
I think you still could rely on their childhood growth chart. You know, you don't
Good
really
to know. When we have a trans boy who becomes a trans male and is on testosterone, how much, do you have any idea, Dr. Dodson, how much extra muscle mass they may accumulate as a result of being on testosterone? Is there a percentage, you know, just as a ballpark?
Yeah, such a good question. I don't know of a percentage. I just know it depends very much on exercise.
Gotcha.
So yeah, that's really which people sometimes are disappointed at when they hear that it doesn't just it's like the whole
yes.
It does depend on exercise, but so I think it's more just that when you are physiologically male, the same amount of exercise, you know, will produce more muscle,
Gotcha.
than if you're a cisgender girl. Yeah.
Gotcha. So actually perhaps being a bit more conservative there with what we assume. Gotcha. All right. Other questions, we've got a few here. Next one is from Beth Cotter. How would you address, and do you address, weight management interventions, in inverted commas, for transgender patients who are so-called overweight, obese?
Oh, I know. Yeah. I mean, I just really try to take the focus off of weight almost entirely. I feel like what I try to do, I mean, I'm sure that I could take lessons from the audience more so than the other way around, but the way I've learned to talk about weight over all this time is to almost not talk about it unless so there are times when you do have to talk about it, when it's really accelerating, you know, when the BMI is absolutely accelerating and there's health sequelae, sleep apnea, things like that. But for most teens, that's not the case. So I think my general practice is to really only speak about your lifestyle and things that you think are healthy and things that could be healthier. So I try to universalize my advice. So I don't speak in terms of you, I say we all. So we all, you know, everyone on planet Earth should eat a diet really rich in plants. We know that. We should all eat things that grow out of the ground. And then I say fruits, veggies, nuts, and beans are so good for us. And, you know, we should all eat, if we're meat eaters, in moderation. We should eat starches in moderation. We should enjoy our desserts mindfully. And if we're going to enjoy some ice cream, just sit and really enjoy it. And none of us should drink too much sugar. And then I really try to focus on exercise as just a way of staying healthy. And then I say, all of us need to find a way to exercise. I know it's hard for everybody. There's always another thing that's more important to do, but people who exercise have lives that are just a lot healthier than people who don't exercise. Absolutely. And so, you know, and I have my oldest daughter's on the cusp of teenhood. So I'm thinking about that, always how to talk about food in this house. And I just think, and then I also just try to say, and by the way, sometimes you're going to eat when you're not hungry because your friend's mom made muffins and you don't want to be rude, and that's fine. Or you're going to eat because you're stressed out, or you're studying late, or you're out with your friends. That's fine. You know, that's normal human behavior, and food is a real pleasure. So I just try to focus on behaviors. And then if I have a kid who's trying to address their weight, or the parent wants me to address weight, I really just try to say, we all do things that are healthy and unhealthy. What are you doing that's healthy? What do you think you could do that would be better for your health? And then they say, well, I don't really move a lot. Well, yeah, we just had the pandemic. I hear you. Like, what's a way you could get, you know? So I, again, just keep it non-judgmental and focused on lifestyle and behaviors, and not, if the number on the scale doesn't change, that's probably okay. If you're telling me now you started exercising 3 times a week, well, that's pretty good, you know?
Yeah, absolutely. I love that. So true. And Beth's comment, along with her question, which presents the dilemma here, is Beth says she works as an RD with adolescent medicine providers who treat both eating disorders, gender and weight management. And she's often asked to meet with patients who so-called need weight loss. And she feels in a bind of having great sensitivity to red flags of disordered eating, but meeting the requests of the MDs who are working with. Yeah, absolutely. And I agree with you in the sense of, looking at, those universal truths and not focusing on a number. And it's really hard because the reality is so many of our healthcare professionals, RDs included, we've all actually been trained in this idea of, if someone's overweight or so-called obese, then we have to go in with a weight management tool and weight loss is good. And we now know that it's not. So it is so tricky, and 95% of diets fail and all of that sort of stuff. So I don't know, Beth, if going in with some information and some studies on that could be helpful to you. Another comment then is from Beth, do you have any resources to direct regarding energy needs and transgender teens or adolescents? Any resources?
Yeah, resources like, yeah, I just think, I hate to get so intuitive. I think that in general, the process of transitioning doesn't change your metabolic needs so much. It's more just that, people, it's almost like if it's sort of like it can be a second puberty for people, so like sometimes people are, when you're 11 years old and you're going through a growth spurt and you can't stop eating and this kind of thing, and your shoes are getting bigger every 2 months, you're naturally hungrier. And I think that particularly for trans boys, when they start testosterone, they may feel a little bit of that pubertal hunger again, especially if they're growing taller, because some of them do get quite a little growth spurt if they've timed their testosterone right. So I think just recognizing that they're in another, that they may be going through another puberty. And so if they have a bigger appetite, it's normal and they should listen to it. I think that would really be the key there, especially for the trans boys.
Absolutely.
Because they are going to be gaining, they're likely going to be putting on muscle mass and even linear height,
Yeah. Absolutely. Here they're intuitive, being as intuitive you can. Next question we have from Valerie. In a patient with anorexia, how long would you want them to be medically stable, weight restored, before prescribing hormones?
Yeah, that's a really good question. I think that I don't think that they're back to that thing about roadblocks. Like I don't want to be another person who's putting up roadblocks and saying, you need to be stable for 6 months. But what I would want is, there comes a time when everyone agrees that somebody's recovered. So from my standpoint, I say, okay, you are menstruating. Your vital signs are beautiful. Your extremities are nice and warm. Your labs look normal. Medically, you look nourished. I'm going to pass the talking stick over to your psychologist, and the psychologist will say, this is a person with, very little eating disorder psychopathology left. Their brain is clear. You know how anorexia kind of fills somebody's head up so they can't think about anything else. So as the anorexia shrinks down and the weight comes back to normal, well, the normal adolescent development starts again. And so I think when somebody's at that place, if somebody's maybe maintained, what we generally say is, menstrual resumption really means like 3 periods in a row, then you really know that this is somebody who's healthy again. If somebody has 3 months of menstruation and their therapist is saying, this person is really in recovery, that doesn't mean free of any eating disorder thoughts. We know that those can linger, and that gets worked on in therapy and over time. And they continue to have a persistent, consistent gender identity, I would start to think about transitioning that person, For Kai, the example in my talk, I think he first expressed gender identity at 11. So for that age, I might wait till that 15 or 16, maybe closer to 15, depending on where he was at age 15-year cutoff, just to think about hormones.
Interesting. Okay, great. The next one from Susan, similar to the previous question, when do you switch gender for estimating energy and protein needs?
Yeah, I I think part of it is that because I was, I think because I don't have the brain of a dietitian in terms of like estimating protein needs. I think my shortcomings are coming out here. I think I just I don't think that I do you switch genders when I think metabolically, because most people still do stick to their growth chart mostly.
Mhm.
The one time when you see if you have a trans boy that gets that growth spurt, when they start testosterone,
Yeah.
then I might start to think more in terms of male. Now,
Yes.
if somebody had gender dysphoria from the time they're age 4 and they've been on puberty blockers, they've never gone through let's say they never went through a female puberty, they've identified as a boy since age 5, and they've never gone through a female puberty, and they're going to start on testosterone. Well, that person physiologically I would think of as a boy, because
Yeah.
they're never going to, they're not physiologically female.
Yeah, absolutely. That's a really helpful distinction, I think, with those hormone blockers as a key piece, which brings up, and I know that this is probably a longer conversation, but it has really struck me in your presentation today, Dr. Dodson, how important it can be for the mental health of our transgender clients, to really listen to our kids early on, if in fact they can communicate this. Because if you can really get the care and the attention and the understanding at an early enough age and do the hormone blockers, then as far as should they choose to transition later with the help of hormones, a greater perhaps outcome as far as mental health and how comfortable they feel in their body is what I'm really hearing there. But a lot for us all to learn there. Okay, next question. Great, loving all these questions that are coming in. We've got a few more and we're okay for time if you're okay, Dr. Dodson. Let's have a look here. Couple of questions about just the presentation. Yes, we have recorded it and we will be sending out a link to everyone who registered. So if you arrived late or would like to view it again, you will have that ability. Next question is from Valerie. In a patient with, okay, we already had that one. Next one is, from Alina, how do you approach gender dysphoric patients when it comes to prioritizing their eating disorders, especially when they feel that the ED is a consequence of their gender dysphoria?
Yeah, I think that is really hard. And I think that no matter what we do, we can always affirm someone's gender. So I have said, I actually spend a lot of time of my day talking with teens and saying, just because we're not doing something medically right now, it doesn't mean that I don't believe you. It's just that what you have is a life-threatening eating disorder right now, and we have to address that medically. Maybe a side benefit of that is that the teen knows that they do have to recover in order to move forward with gender management. Is that sort of a sneaky goal of mine? Maybe, but also I think it would be kind of a bit reckless and medically irresponsible to start gender affirming care on somebody who's actively getting sicker from an eating disorder.
Yeah.
So I think the way that I would break it down is that, to me, anorexia is a life-threatening diagnosis that impairs your rationality. It impairs your ability to be insightful about your own health, and to make, decisions about your own health. And so anorexia has to be treated and stabilized before beginning to discuss the medical treatment of gender dysphoria. But in my mind, bulimia is really different. Somebody once did this beautiful thing where they showed a Venn diagram of a person and their anorexia, and they were sort of overlapped, like the anorexia kind of takes over the mind of somebody, leaves very little rationality left, whereas bulimia tends to be separate from the person. It's a behavior that they're doing, but it tends not to impair their rationality as much, and people tend to stay more medically stable. And so to me, that's a situation where it's okay to medically pursue both paths together, and I say, listen, you're going to keep working on decreasing purging. We're also going to move forward with treating your gender. Oftentimes bulimia comes with other self-harming behaviors other than just purging. So it's sort of like, it's a bit of a juggling act, but we're, watching usually a lot of behaviors at once. And so we can proceed with gender affirming care as long as they're in the care of a therapist who recommends that step.
Yeah, absolutely. I'm thinking about some of our clients as well, Dr. Dodson, and I'm thinking that I would imagine there's real fear among a trans boy who has been maybe intentionally or unintentionally restricting in order to prevent the onset of puberty. And then we're saying, hey, you've got anorexia and we need you to eat. And knowing that that will therefore possibly bring on the developmental changes into a female body, I imagine that would be really hard for our trans boys.
Oh yeah, I guess I should clarify. I'm so sorry. I feel like there's so many different pathways that we could be thinking of. If somebody, yeah, so let's talk. So yeah, I was thinking when someone asked that question, I was thinking in terms of hormones, but let's step back and talk about puberty blockers. Yeah. So if somebody is actively restricting, similar to sort of the first case that I mentioned, if someone was actively restricting and obviously in desperate need of puberty blockers, I think that that's a situation where I'm trying to think if I've ever had that situation. I don't know if I've ever had that, situation where somebody was like very sick with true anorexia and needing puberty blockers. I think what I would do is at least stabilize them at the most basic level. I'd say to them, you have to show me that you're not actively losing weight. Like basically you need to turn this train around. If it's going in the right direction and you're in care, we can block your puberty, so it's not like somebody would, because you're right, puberty is a time sensitive issue, and it's that's a bit of an emergency for the patient. So just as anorexia is an emergency, the wrong puberty is an emergency.
Exactly.
So
yes.
Pull back and clarify that.
Yeah.
I would try to stabilize them enough so that I'm not worried about their immediate, like the safety of their life. And to be honest, I'm in the real world of puberty blockers. You prescribe a puberty blocker, and then there's about 10,000 forms that get faxed back and forth, and then the whole process takes longer than you could ever imagine. Mm-hmm. And so, if I'm ever thinking medically somebody's going to need a puberty blocker, I start the process anyway, because we're going to grow old and gray waiting for that to be approved anyway. And in the meantime, yes, we would actively be stabilizing them in terms of their eating disorder.
Wow. Great information there. And then one of the last questions, which is great, perfect timing here, from Janie. Janie asks, are there any suggestions for finding MDs that treat EDs and gender dysphoria around the country?
Yes, so there are. So probably your best bet as to the field, I'm part of this very tiny little field of medicine called adolescent medicine. I feel like we're like the small but mighty field. And I think we're the field that treats those two, and over time we've come to understand that they're interconnected, so we treat them together. So I think what I would do if you wanted around the country would be to go through the Society for Adolescent Health and Medicine, SAHM, Society for Adolescent Health and Medicine, and that's where you would find a directory of adolescent medicine doctors. And so, and in general, whatever city you're looking in, if you're like, oh, who in San Diego could take care of this person, you could look up San Diego Adolescent Medicine, and those would be the doctors that would do it. So that's sort of a little plug for my field in general.
That's fantastic. Really, really helpful. We actually do have a couple more questions. One from Sari. Does Dr. Dodson have a referral list she can share, especially for therapists? This is for therapists with expertise in eating disorders and gender dysphoria.
Yeah, what I could do is send it to you, Melainie, and maybe you could distribute it to the group.
I would love to.
Yeah, let me do that, because I certainly, and yeah, I mean, I have sort of like a New York-based network.
Yes.
So yeah, absolutely, I can share that with you.
That would be fantastic. Thank you. And we'll send that out to our participants along with the link from today's recording as well. And lastly, from Susan, do you find Vyvanse to be helpful in trans patients with binge eating disorder, especially if traditional therapy and structured eating have not decreased the severity and frequency of binges?
Yeah, Vyvanse has helped some of my patients. It has, I believe, for binge eating disorder, you know, topiramate also has some evidence, although that teens do not like the foggy brain that goes along with that. So yeah, Vyvanse does have some efficacy. I haven't started it on more than a couple of patients myself, but I've had patients come to me on it and say that it has helped for sure. Yeah. Binge eating disorder is sort of, it's like bulimia really, in that it's one of these conditions that, you know, I try to have the long view. It gets better over time with therapy. There's, you know, there's sort of cognitive behavioral workbooks, one by Jenny Kramer called Overcoming Binge Eating, which I'm looking at on my bookshelf right now, Overcoming Binge Eating, that helps people. But Vyvanse does have some efficacy.
Absolutely wonderful. Thanks so much for that. And thank you to all our participants for their wonderful questions. I would just like to just let our audience know that at Balance, at my treatment center, we definitely treat binge eating disorder. It's actually my area of specialty. And we take our clients from structured eating through to intuitive eating. It does take a lot of time because usually our binge eating disorder clients have struggled with it. Usually they present more as adults. So it does take time, but we really get them through to that cycle of a more neutral place with food, through food therapy and food exposures, etc. So there is that ability for sure, just to let people know. So we're almost out of time. So I just want to thank you again, Dr. Dodson, for a really, really informative presentation today. I learned so much, and I also want to thank our participants for these great questions. As I mentioned earlier, we'll be sending out the link and also the therapy referral list that Dr. Dodson has for therapists who work with eating disorders and gender dysphoria. So we can get that out to you all in the next day or so. And again, just here at Balance Eating Disorder Treatment Center, we are back in person. And I'm also thrilled to announce that we have been awarded or certified with our Office of Mental Health, New York State mental health clinic license. What that means is our clients can now get more access to their out-of-network benefits and therefore more accessible care through our programs. So I hope that might be helpful to any of you. And also our psychiatrist on staff is very active in the LGBT community. So this is a topic near and dear to our hearts. Thank you all again. And again, Dr. Dodson, we're so grateful. Thanks to everyone.